Good evening, everyone. Thank you for joining us here at the ISEH webinar. I'm Sam Oussedik. I'm your chairman for the meeting this evening. I'm a knee surgeon, but we've got a full roster of speakers this evening who are going to talk to you about their interesting subjects, topics all around managing the injured adolescent athlete. So we've got wonderful talks for you. I hope you'll enjoy them all. I know these are very knowledgeable speakers, one and all, and I certainly always gain a great deal from listening to them. There's a lot of wisdom that's going to be imparted. Now, there are a few little housekeeping bits. You can ask questions of our speakers. There's a Slido Q&A box, and we will do our best to address those when we come to the Q&A session at the end of the talks. So rather than stop after each talk, we're going to have all the speakers join us at the end in order to go through those questions. So do put those in there if you wish. And the other thing to say is that this webinar, this virtual conference, is being recorded. So a link is going to be sent to you by HCA, and you can, if you miss something or you want to have another look, or certainly share it with your friends, then that will be sent to you so that you can have another look if and when you need to. I'll just, before, as the lights go off, before we move on, I'll just, whilst I remember, signpost you to the fact that this is the first of two webinars, and tomorrow we have another topic with another chair and another slate of speakers talking about the expert care for the collapsing athlete. So you might want to tune into that tomorrow evening. Certainly that sounds like a really good topic, very timely and important to look at. So I probably won't talk very much more, but I will pop up after this first talk. The first talk of the evening is by Dr. Rick Seah. Rick, as I'm sure all know, is a consultant in sports and exercise medicine, and he's going to talk us through common upper limb musculoskeletal problems in adolescent athletes. So sit back, enjoy, and I'll see you the far side of this.
Thank you for giving me the opportunity to speak to you. My name is Ricci. I'm going to talk to you about common upper limb musculoskeletal problems in adolescent athletes. So I have no disclosures to make. In terms of background, I'm a general MSK and sports physician. I work in the NHS and also in the independent sector at ISEH. I recognize that this is a large and varied audience from all walks of life, some of whom are just starting your journey in healthcare, others are very experienced practitioners. If it's okay with you, I'm going to try and pitch for a talk somewhere in the middle. This is a fairly large and varied topic for 15 minutes, and I've had to be quite selective. So for that reason, I've picked 5 injuries to talk about. There's a diagram on the top right that you can refer to, but basically 3 involving the shoulder joint, 1 involving the elbow, and 1 involving the wrist. To give you an overview of the talk, there's 6 areas that I'd like to cover. Firstly, is this a common problem? Talk about definitions and concepts. Talk about growth plate injuries, which are common in this age group. Talk about upper limb injuries by anatomy. Give you some take-home points to consider, and then give you the bibliography and references if you want to read around the subject in a bit more detail. Is this a common problem? So if we look at the United States, pre-pandemic, an estimated 60 million kids between the ages of 6 to 18 years participate in organized sport yearly. And among these sports, overhead sports like baseball and basketball have been reported as the most popular. And that's quite relevant to a couple of the injuries I'm going to talk about. If we look at the UK, this is an article from the BBC a few years back. Children and adolescents account for half of sport A&E attendances, and about a quarter of the injuries were fractures, most commonly to the upper limb. In terms of what causes these injuries, football came to the top of the list for boys and trampolining for girls, but bearing in mind this was for all types of injuries, upper limb, lower limb, and spine. I'll give you some definitions, talk a bit about terminology. So we're all guilty of using the terms interchangeably, myself especially. So children, kids, youths, younger persons or people. Just to keep it a bit more snappy in this talk, I'm going to use the term kids. Adolescence is the period of time where a younger person has become puberty, but not yet become an adult. And typically the age range for that is about 10 to 19 years. If we look at cutoffs where patients might transition from a pediatric unit to an adult unit in healthcare. Some units have a cutoff of age 16 and below, others 18 years and below. For the purposes of this talk, I'm going to refer to 18 years of age and below. In terms of concepts, just so you know, and I'm sure a lot of you are aware of this already, kids are not equivalent to little adults. And the main difference is that they're skeletally immature. They're still affected by growth spurts. Females between the ages of about 9 to 15, and they typically start a bit younger than the males. Males from about 12 to 17 years. And anecdotally, my patient population where I see a lot of these injuries tend to be between about 12 to 16 years. If we talk about growth plate or physeal injuries, the growth plate, the physis is the growth plate, and is a cartilaginous structure that allows for longitudinal growth of the immature skeleton. There's one at either end of a long bone. So here's an example of a femur in the lower limb, the thigh bone. You've got your proximal physis in blue at the top and the distal physis at the bottom in blue as well. And those are quite commonly affected in this population. With growth plate injuries and skeletal immaturity, the reason this is relevant is that mechanisms of injury that will cause ligament sprains in adults are more likely to cause growth plate fractures in kids. And I will give you an example of this later when I talk about ACJ or acromioclavicular joint injuries. Physeal fractures make about 15 to 30% of all fractures in kids. Typically, males are more commonly affected than females in 2 to 1 proportion. Occurs more frequently in adolescents during periods of rapid growth where the physis is vulnerable and therefore weaker. And we're aware of the Salter-Harris fracture classification for growth plate injuries. So moving on to my first injury, talk about the little league shoulder. This is a stress fracture involving the proximal humeral physis or the growth plate. And I have it in the top diagram on the right with those arrows showing a thickened and slightly irregular growth plate. This is common in pitching and throwing sports. You see this more in the USA in baseball, but in the UK, you also see it in injuries, for example, with tennis and volleyball, less so in cricket due to the mechanism of throwing involving the lumbar spine. With age group, 11 to 14 years is common. And the considerations for this injury, which actually apply to a lot of the other injuries I'll talk about, involve a growth spurt, repetitive stress on the joint, inadequate rest between competition and training, suboptimal pitching or throwing technique, and frequency of pitching. And often it's a combination of factors, perhaps too much of one, too little of the other, that give rise to this injury. The management of this is usually conservative. Involves resting from pitching, typically 4 more weeks. Important to improve the technique by getting the coach involved. There's a role for imaging to monitor progress, usually the use of plain radiographs or X-rays, but you can also consider cross-sectional imaging like MRI or CT. And the idea of a pitch count, which is to say to limit the amount of pitching during a given week or in any training session or competition is quite common in the USA. We then move on to the second injury, which is shoulder dislocation. This involves the glenohumeral joint, the GHJ, which is a ball and socket joint. And the concept was one of a large golf ball resting on a small tee. And the reason for this is that you have to balance excellent range of motion considerations with stability in the shoulder. And if you compare that to the lower limb, the hip joint, which is a very similar joint, also a ball and socket, you have excellent stability in the hip joint, which is why it doesn't dislocate so much. But the trade-off is that you have reduced range of motion. So the injury occurs when the humeral head, the ball, comes out of the glenoid, the socket, giving rise to a dislocation. And in this instance, both joint surfaces are not in contact with each other as compared to a joint subluxation where the two surfaces may still be in partial communication. An example of this is the picture on the right, which is actually a picture of an adult shoulder, as you can see, because there aren't any growth plates. But to show you, this is an anterior dislocation, which is most common, and the two surfaces are not in communication with each other. And causes of this fall onto outstretched arm, or resisted abducted, externally rotated position of the shoulder. The first episode is normally very painful. There's pain, deformity, and loss of function. Often you need to be seen in the emergency department to relocate the joint. And there's other considerations such as fractures, neurological vascular involvement, and soft tissue injuries such as labral tears or glenohumeral ligament injuries. Management is conservative initially. You offload from sports for 4 to 8 weeks. You place the arm in a sling. You get physiotherapy. There's concerns about recurrence. There's concerns about acute traumatic shoulder instability, which can give rise to longer-term issues with degenerative change in the glenohumeral joint. And in some patients, there is a role for surgery. The third injury involves the shoulder separation, which is the AC or acromioclavicular joint ligament injury. This is actually not a very good phrase, and I think the term shoulder separation causes a bit of anxiety in patients and parents. There are growth plates at this site, and I've shown you two pictures here. The one on the left involves an adolescent with ACJ widening where the arrow points. The one on the right is actually that in an adult where you have ACJ ligament sprain and different grades of that. Causes of this injury involve overuse or trauma sustained at the top of the shoulder, for example, from a fall. You tend to get point tenderness and there's localized swelling. Weighted plain radiographs or x-rays can be useful to show the ACJ widening. And management is mostly conservative, offloading from sport, use of a sling or physiotherapy, and surgery generally not required. Next injury, we move on to the elbow. We talk about the little league elbow, which is once again a bit more common in the USA. This is formerly known as the medial epicondyle apophysitis. So the medial epicondyle is to the inside of the elbow where the elbow juts out. And it arises in the skeletally immature athlete with open physis, typically under the age of 10 years. The developing apophysitis and physis are weaker, the flexors that come from the medial elbow, and therefore it becomes quite prone to injury when you pitch with repetitive valgus stress and traction at the medial epicondyle. And you mainly see this in throwing athletes such as baseball players during the cocking phase of throwing, where you get increased valgus stress on the medial elbow. X-rays are helpful. You can look for widening of the medial epicondyle physis. There might be bone fragmentation. There's a ragged appearance. You might see sclerosis or trabecular thickening. MRI is also helpful. You see evidence of inflammation as well and bone marrow edema. And ultrasound can be helpful from a screening perspective. You can detect early lesions, including bone cortical discontinuity or fragmentation. Typically, they present with insidious onset medial elbow pain with throwing. There's focal tenderness on palpation to the inside of the elbow. You might get localized elbow swelling, limited elbow extension and stiffness. Management is conservative generally. You have to stop all throwing activities for between 4 to 6 weeks as a minimum. Physiotherapy is helpful with a graduated return to throwing. And on average total time to return to competitive pitching is about 8 to 12 weeks. And once again, the idea of pitch counts. Finally, the last injury I'm going to talk about is in the hand and wrist involving scaphoid fractures. And this is the most commonly encountered carpal bone fracture, which represents about 70% of all carpal fractures. Typically, you get a fall onto an outstretched hand. You see it in contact sports such as football or rugby, or high velocity sports such as skateboarding or rollerblading. Typically, in the pediatric population, it tends to occur at the distal part of scaphoid, distal pole or the scaphoid tubercle. More recently, you get it somewhere in the middle or the waist of the scaphoid, which is thought to relate to increased body mass index and also increased participation in high impact and extreme sports at a younger age. It usually presents after trauma with acute wrist pain. There's tenderness to palpation of the anatomical snuff box. There's pain noted with radial deviation, and pain is typically to the radial aspect of the wrist. Plain films are helpful, including dedicated scaphoid views, which may or may not show a fracture line. Where there's high clinical suspicion and normal plain radiographs, you might get cross-sectional imaging such as CT or MRI. And if that's not available, you might repeat plain radiographs in 10 to 14 days and look for signs of sclerosis or early healing changes. Ultrasound is generally not so helpful for these type of injuries. Once you confirm it, you immobilize it in a thumb spiker cast. Depending on where the injury is, you might immobilize it for 4 to 8 weeks with a distal pole fracture, and slightly longer for a waist fracture, which is up to 15 weeks. Generally, they do well with casting if it's non-displaced, with reports of a 90% union rate. If there are any issues, you might look to surgical reduction with internal fixation, with or without bone grafting, for acute displaced fractures, late presenting fractures, typically more than 6 weeks, or chronic non-union fractures. And post-surgical union rates are reported to be at least 95%. And don't forget the role of hand physiotherapy when out of the thumb spiker cast. So some take-home points. Upper limb injuries from sport are common in younger athletes. The shoulder is most commonly affected, followed by the elbow and wrist. Scaphoid fracture is the most common carpal bone fracture. In this age group, they are prone to growth plate or physeal injuries. If there's any doubt, get medical advice and consider imaging. And fortunately, many upper limb injuries can be managed conservatively in this age group. And these are the bibliography and references if you want to read about it in a bit more detail. So thank you very much, and I hope you found it helpful.
That was great. Thank you, Rick. And so keep your questions coming in. I can see they've started coming in already on the Slido. And as I say, we will address those at the end of the webinar once all the speakers have spoken. So I will keep check on them and come back to them at the end. So do type them in, and I hope we'll get everything answered and cleared up for you. So that was a really great whistle-stop tour through the upper limb injuries for adolescent athletes. And now we're very fortunate to have Noel Pollock join us. So Noel is also a sports and exercise physician, as I'm sure all of you know, and Noel's an expert in lower limb injuries, and so that's what he's going to focus on for his talk. So over to Noel.
Thank you very much for the invitation, and it's a pleasure to talk to you this evening on adolescent lower limb injuries. I'll primarily discuss apophyseal injuries and bone stress injuries in adolescents, but also discuss some rare conditions that it's important not to miss. To start, just with some general background and principles, and to place this presentation in context. Physical activity is obviously important at all stages of life, and particularly in adolescence, and it's a common time, particularly in female adolescents, for dropout from sport and physical activity, and injuries are an important part of that, and therefore the accurate diagnosis and treatment of injuries can enable a continued participation in sport and exercise. Also important to realize that there's lots of different contextual factors for every individual and every adolescent, be it studying and the reasons in which they participate in sport, and those will be important to explore during the consultation. Also, in adolescent athletes in this football team demonstrates visually the range of different body sizes at this particular stage of their life, and having an awareness of growth and maturation in adolescent athletes is obviously very important. Age can be considered both from a chronological perspective, but more importantly from a skeletal perspective, and of course from a psychological maturation as well. So an awareness of this graph, which demonstrates height velocity in growth per year, can give important context to how you manage and look after these young people. Females' growth accelerates around the age of 9 to 10, with a peak height velocity usually of around 12, whereas males is a little later, with a peak height velocity usually around the age of 14. But this is non-linear, and there are also early and late maturers. So having an idea of where the patient may be on this graph in terms of their growth can give some indication of the sort of injuries that they might present with, but also some other considerations that particularly around the time of peak height velocity, there can be a reduction in movement quality at the same time that they're developing explosive strength and increases in speed and agility, which can make them vulnerable to injury. And changing the training intensities or working more on some coordination drills and movements and technical aspects during this time can also be of help. Just in terms of terminology, I'll be speaking a lot about the apophysis, which is not the site of longitudinal growth in the bones, which is the epiphysis and metaphysis growth plate. But the apophysis is where the tendons attach onto the long bones, and they're a site that's vulnerable to traction at those tendon attachments. These type of injuries are usually considered as a overload or overuse type injuries, and the first attention usually goes to the training plan in terms of the volume and the intensity and the pace of the increases in loads. That can also be broken down further into specific loads within the training plan. So specific number of serves in tennis, or number of sprints, or number of hops and jumps, maybe very specific loads that you want to take a record of. But these should also be balanced between the intrinsic risk factors, which will influence how the person, patient, adolescent responds to that training plan. So individual factors that affect their recovery. The nutrition practices and relative energy deficiency in sport is much an issue in adolescent athletes as it is older athletes. Their endurance capacity, their technical competency in biomechanics, the footwear they use and the surface they train on are all important things to consider. And by way of illustration, I'd like to show this a short video of two athletes running around a track. If both of these athletes presented with Achilles tendon insertional pain, like Sever's apophysitis, or in later life as Achilles tendinopathy, just take a look at how they land. And if you've got a sort of a generic approach to the treatment of Achilles tendinopathy, you may miss important factors in this group. So athlete in the white socks, it's a very different landing strategy on their forefoot than the athlete with the shorter socks. And you miss the fact that they're landing on their forefoot for every running stride with huge loads on the calf and the Achilles complex. You might miss the most important factor as to why this athlete is presenting with Achilles tendon pain. There have been some good resources and research produced in recent years on warm-ups and movement quality. This 11 plus program from FIFA is really excellent, and online resources of this are available, and just gives you a nice structured warm-up for drills that can be included in a warm-up that improve multi-directional coordination and technical qualities, and I'd highly recommend that resource. Also, often sort of considered, when should strength training start in kids, and there's often fear of introducing weighted or strength-based training, and this can sometimes come from coaches and sometimes come from parents, and often comes from parents. But really, there's some also excellent resources on the importance of beginning strength training in young and adolescent athletes. This has performance and health benefits. It's beneficial for the bone and the tendon connective tissue attachment. It's important for coordination, for developing the technical competencies for strength and conditioning in the future. In general, these strength programs should use free weights and multiple sets with a focus a little more on endurance, movement quality, and the development of technical competency. But this can be a really important part of training for adolescents, but also at times of injury when you may be modifying other elements of their training. It can be an incredibly useful thing to add in, which can improve both their health, their injury risk, as well as their performance. So more traditionally, these kind of overload and overuse injuries, the approach has been to reduce training, restrict activity, rest from activity with a focus on reducing the pain. But perhaps a better approach and a more empowering approach would be to develop competencies in technique and biomechanics for that sport, develop strength qualities, and develop strategies to deal with complex movements and plyometric movements. And usually, just changing the emphasis of the training program at that time of injury can be done with this type of injury. Discussing excellent recovery practices, including sleep, nutrition, warm up, can be something that the athletes can then incorporate into their sport, which can be really helpful for future sports performance as well as injury risk reduction. So to talk more specifically about apophyseal injuries, primarily, adolescents presenting with persistent focal pain should not be attributed to growing pain. Apophyseal injuries are at some classic sites. I've got examples here of severs apophysitis, the Achilles tendon insertion, the patella tendon origin insertion in Sinding-Larsen-Johansson syndrome and Osgood-Schlatters, and then the pelvic apophysitis at the sartorius and rectus femoris attachments, as well as the hamstring attachment and the ischial tuberosity. And there is a difference at the age at which these present, with the distal apophysitis usually presenting early at age 10, 11, and 12, and then a spike in the knee apophysitis with the pelvic injuries later in adolescence. They usually present of gradual onset, and players will initially and may for some time continue to play. This nice graph from the Hespenol paper demonstrates just the length of time that some of these injuries can present over. They initially cause pain, but the player continues, but then it might slightly reduce their performance, which may not be particularly noticed. It may only be when it starts to affect their participation or a true time loss from sport that is recognized as an injury. Obviously, picking things up at the earlier stages can allow you to put management strategies in place. As I mentioned, they usually got a very specific site of pain at the tendon attachments, and they occur during periods of growth. Examination is usually very straightforward. They're focally tender at the attachment, and pain on stretch and resisted contraction. They will often have a bony prominence, particularly if there's a chronicity to the presentation, and they may have local inflammatory signs. And ultrasound in clinic is usually sufficient to make the diagnosis, but there are some indications for MRI scan, particularly if there's an acute incident, sudden onset of pain or significant loss of function. These are some MRI examples of pelvic apophyseal injuries. The first one demonstrating high signal at the rectus femoris origin. A little bit later in its onset will be apophyseal injury at the sartorius attachment. This is demonstrating a bony avulsion at the ASIS. And then finally, in the third image is the high signal at the hamstring apophysis, which can present very chronically, and often players continue for many weeks with slowly developing pain at the hamstring origin. So the management is firstly one of education, an explanation of the condition, reassurance in general that this will usually settle or always settle whenever growth slows and as adolescent gets older. I think it's really important to have a conversation about that link between load and adaptation and recovery, as well as all of those intrinsic factors that can affect recovery from sport and recovery from injury. You may want to modify some of the higher risk loads, which will be different depending on the apophyseal injury in question, whether that's volume of jumps or kicks, or the type of kicks, or powerful shots. You may ask them to look at their overall training week and prioritize the key sports that they want to participate in. So you may keep some of the really high loads in, but take out some of the other loads which are less important, but allow them to continue at their favorite sport. And this is a great time to work on other aspects of athletic development, both from an injury treatment perspective as well as an injury prevention perspective. And strength and technical development are usually important things to focus on at this stage. Parents are obviously a very important part of the consultation and the assessment, and the education discussion about the nature of this injury is really important to involve the parents in that, because they'll often have their own experiences and perception of injury and injury risk factors, or things that they think that the child should prioritize on recovery. And it's important to sort of explore where those thoughts and biases are, because that will certainly influence what happens with the patient at home. Obviously important to explore the patient and adolescent's wishes and concerns themselves, and be aware that there may be hidden information that might only come out with as your relationship develops with the parent and the adolescent. Some cases, particularly around elite adolescent sport, parents may not always have the child's health as priority, and important to reflect and be aware of that. And if there is a conversation or a decision that's making you feel a little unsure about or a little uncomfortable, that sharing that discussion with a colleague and seeking a second opinion can be invaluable. In terms of symptom management, some simple strategies like a gel heel raise for severs, Achilles, apophysitis can be really helpful, and might be the only thing that's needed to control symptoms while you work on some of the other risk factors. And similarly, reviewing footwear, short-term use of topical or oral anti-inflammatories can be very helpful. A shockwave therapy can be useful in transient, in persistent cases. Stretching is often advocated in the treatment of apophyseal injuries. My personal experience and thoughts on that are that in general, an aggressive stretching program is not something that's particularly helpful, and is as likely to irritate the apophysis as it is to resolve any perceived inflexibility or movement restriction. So that's not something that I usually advocate strongly for. The evidence of the role of a lack of flexibility in presentation of these is not strong. Equally, ice, while it can be useful after a particularly difficult session that's resulted in an increase in pain, in general, I think heat is more helpful for recovery and adaptation. And then the more significant apophyseal injuries, those of avulsion, will usually present acutely with a very specific mechanism and incident. This usually occurs around the pelvic apophyseal injuries rather than the knee or Achilles. And therefore, patients are usually a little older. MRI is usually the most important investigation of choice, although X-ray may have a role in some of these. These are usually rehabilitation cases, although if there's significant displacement beyond 1 to 1.5 centimeters, certainly worth considering surgical discussion, particularly in elite adolescents. Greater than 2 centimeters is likely an indication for surgery. A nice paper published in 2021 demonstrating a correlation between MRI displacement and return to sport, with displacement of less than 3 millimeters being associated with a 40-day return. But these are generally significant injuries that require time off sport and progressive rehabilitation, which is time and criteria dependent rather than necessarily pain dependent. These can be vulnerable to further injury and further displacement. A repeat MRI scan can be useful to demonstrate recovery, and they need a staged and progressive rehabilitation. Some are associated with longer-term complications. Classically, this subspinous impingement of the rectus femoris due to bony and calcific overgrowth. And this is one example of a high hamstring apophyseal injury with a small retraction, but I saw this patient a few months after their acute incident. Repeat MRI scan demonstrated persistent gap. However, the function was relatively well maintained from a clinical perspective, and therefore we progressed with a rehabilitation plan. 3 or 4 months later, they had ongoing signs on MRI scan, but still function was well maintained. And although at this stage, patients' parents were keen for surgical intervention, and that was an option for them, we did persist with rehabilitation, given the good function and the progressive improvements that they were making. And at 9 to 10 months from the initial injury, demonstrating good radiological improvements. So these can take some time to demonstrate radiological improvement, but if clinical progress is good or worth persisting with. And then bone stress injuries, similar in terms of their presentation and the risk factor assessments that you will make. I think I'd just like to point out some of the high risk stress fracture sites. And if you get focal pain in any of these areas with young athletes, these are important injuries to investigate and diagnose. Early detection of bone stress at these points has a significant impact on the amount of time lost from sport. So important to diagnose early if you're suspicious of these injuries. And there's some excellent imaging tools at our disposal in order to investigate and pick these up early. And then finally, I'd just like to highlight a few conditions that can present with pain in adolescents that are really important not to miss. So if there's something a little unusual in the history, if the night pain is a feature, if joint pain or swelling is a feature, this is not usually classic with apophyseal presentation. There's an unclear relationship to load and exercise. And if it's not responding to your rehab program, just think again and make sure, and perhaps get further investigations to make sure you're not missing some other diagnoses. Slipped upper femoral epiphysis, a classic injury at the epiphysis, which is a very important one to diagnose, as this can require surgery and requires careful management in the early stages. Classically, these present with hip pain and hip signs, and in the textbooks they're often portrayed as the overweight or obesity, and 50% of kids present with this, but it means that 50% of kids who present with this are not obese, and therefore having this on your radar, even in the slim adolescent who is presenting with hip pain, is important. Tumours occur rarely, but are important to have on your list of differential if there are any of the red flags, or if things are just not recovering as you expect. Obviously, investigating and picking these up early are important. And finally, inflammatory joint conditions. If you've got a joint effusion and swelling, that's an indication for further referral and investigation to confirm rheumatological diagnoses. And so that concludes my presentation on adolescent lower limb injuries. I hope that was of help discussing some of the common presentations, but also some of the important diagnoses of which it's important to be aware. Thank you very much.
Great, thank you, Noel. That was a really comprehensive, actually, run through lower limb injuries in adolescents, and I can see it stimulated a lot of interest, a lot of questions coming through. And once again, I'll get to those with Noel and the other speakers at the end of this webinar, of the recorded elements of the webinar, anyway. Next up, we're staying in the lower limb, and it's one of my colleagues and fellow knee surgeons, Chinmay Gupte. And Jim's going to talk to us about adolescent ACL injuries and indications for surgery. So over to Jim.
Thanks very much. Great pleasure to be here. And my brief today is to speak about adolescent anterior cruciate ligament injuries as someone who treats quite a lot of these in both elite and club athletes. This is our agenda. Let's look at the anatomy, how we diagnose these injuries, indications for surgery, techniques, graft choices, the advent of lateral tenodesis as a supplementary operation, and rehab and injury prevention. The ACL passes from the tibia to the femur or femur to tibia, it doesn't matter which way you look at it. It's mainly on the anteromedial aspect of the tibia, passing backwards, upwards and laterally into the inner aspect of the lateral femoral notch, usually at the back of the notch with the knee in the 90-degree flexed position, which is actually a proximal position with the knee extended. The adolescent knee is different because it has growth plates, it has periosteum, and adolescent collagen in ligaments is generally more elastic, and not only that, hypermobile patients are more likely for ACL injury. Now, adolescents are by definition non-compliant. I have two of my own, and I'm also a parent, so the consultation is a triangle between the clinician, the patient, and the parent, and that involves a different dynamic psychologically. There's no doubt that adolescent injuries are increasing in incidence, and there are many papers showing this, probably because the adolescent frame is growing in size. There's a greater intensity of competitive sports. There's an increased diagnosis because of the availability of MRI scan, and with a greater participation of females in pivoting sports such as netball and football, there is almost an epidemic of female ACL injuries in adolescents. Here's the typical mechanism. It's a non-contact with the foot planted in external rotation, the knee going into valgus, and the knee then going from an extended to a flexed position. Often this involves an MCL and medial collateral ligament injury as well. Now I'm going to restrict my talk to mid-substance ACL injuries rather than tibial spine fractures, which occur in younger children, usually between the ages of 8 and 12. We need to be aware that often these patients have hypermobility, so it's really important to examine the normal knee to understand their normal laxity. Here is a Lachman's test. The knee's at 30 degrees. You can either do it with the left thigh under the right thigh or with your hands, and that will give you a positive test. Thought theoretically to test more the posterolateral bundle. This is the anterior draw. The hamstrings have to be relaxed, and this is a modification of the anterior draw looking for anteromedial laxity. This is really an advanced type test for anteromedial laxity as well as ACL laxity. Moving on to the pivot shift test, the knees in extension with the tibia in valgus and in internal rotation. The nature of the pivot shift test is really this, where the tibia subluxes anteriorly and then the iliotibial band moves it back into a reduced position. MRI scan is the gold standard for diagnosis, and here you can see very high signal with very amorphous anterior cruciate ligament on the sagittal. The PCL is lax and bowed. There is a supplementary Segon fracture, which is obvious on the CT, but sometimes seen on a plain X-ray as well. And you can get a pivot lesion, which is on the posterolateral tibia and anterolateral femur. Now, adolescents' ACLs can be susceptible to partial and stretch injuries more so than adult ACLs. Just in that same patient, it is important to be aware of a fairly uncommon syndrome, which is congenital hyperplasia of the ACL. So this was the same patient who had no injury on the other side, but we scanned it anyway because his knee wasn't quite feeling right, and he had a very hyperplastic anterior cruciate ligament, which in fact did rupture 3 years later, and he underwent an adult ACL reconstruction at that stage of this side. Now, this is what I call the danger zone. Often these children have an injury, they have a painful swollen knee, they can't carry on playing. They're then taken to the emergency department. An x-ray shows no bony injury. They're told they've got a knee sprain. That then resolves with a degree of swelling management. The pain gets better. Patient starts feeling better, perhaps with some physiotherapy. They're back to play, and there is a high rate of re-injury, both to the ACL, but actually more importantly to the meniscus when they are managed conservatively. The meniscus can get damaged, and particularly if they go to a surgeon who's not particularly familiar with meniscus repair, that meniscus gets then taken out at surgery, which then predisposes them to arthritis. And I'm afraid to say that I do have some 20-year-olds with grade 3 chondral wear because their meniscus has been taken out. What we really want is this, which is early diagnosis with MRI scan. And we can come back to why early surgery is important with the right graft, the surgeon doing the operation in the right way, and optimal rehabilitation, which is tailored to an adolescent knee with an injury prevention program and a return to play program. That's what we really want. There is overwhelming evidence for early surgery with a greater return to sport rate, a lower risk of meniscus tear on return to sport, and a lower risk of early degenerative change. And we're always worried about growth abnormality in these growing bones, but that incidence is less than 1 or 2%, probably 0.5%. Here are some further studies suggesting bad result of conservative management. I can't really go into the detail, but there's no doubt that surgery reduces the risk of further injury. So that's really what we want. ACL repair. What about just sticking back the damaged ACL? There's some great techniques, but unfortunately, the results are not borne out by these techniques because the re-rupture rate, the re-injury rate is between 40 and 50% in reported studies after 2 years. And that's probably because the ACL is damaged. The collagen's already stretched and damaged, and you're just putting back stretched and damaged collagen. Now, there may be a role for ACL repair with lateral tenodesis. So in adolescents, there is now a study that's taking place which will look at ACL repair with lateral tenodesis. Suffice it to say the national guidelines are that ACL repair should not be performed in adolescent patients unless they are part of a randomized clinical trial in this country. Now, what about reconstruction? There are lots of options for grafts. The most common is the hamstring tendon graft in the growing knee with an open physis. Quad tendon is becoming more popular. You can't really use patella tendon because the physis extends into the tibial tubercle, and you can get a physeal growth arrest and often a really bad recurvatum if you use the patella tendon and you've damaged the physis. It is more common to use patella tendon in a fully skeletally mature adolescent. I'll come on to those reasons in a minute. The key is the graft size diameter. It should be greater than 8 millimeters, and often we aim for between 8.5 and 9.5 millimeters, even in the younger adolescents. We're trying to achieve a stabilization of this pivot shift issue. We want an easy harvest with minimal domicile mobility. We want the graft to be incorporated, and we want effective rehabilitation with high return to sport, low re-rupture rate, and no growth disturbance. Those are our aims of surgery. The BTB graft does seem to have better incorporation, and in several series, a lower re-rupture rate in fully mature adolescents. If you really look at these, though, the BTB grafts are often bigger. So if you can get the hamstring graft big and stiff and tight, probably the re-rupture rate is the same. The hamstrings, you must not use a hamstring, in my view, less than 8 millimeters, but this study suggested 7 millimeters. There are now techniques, very good techniques, of quadrupling hamstrings or even using an 8-strand graft where you achieve a diameter of 8, 9, sometimes even 10 millimeters, which reduces the re-rupture rate. Hamstrings have a lower donor site morbidity. So here are our pros and cons of using BTB in hamstrings. Okay, this study does suggest a greater risk of revision when using hamstrings, but as I said, they didn't tease out the hamstring graft diameter. Quads is becoming increasingly more popular, And there is good reason for this. It does seem to provide a stiff, thick graft. There is some evidence that in adolescent females, there's a difficulty in regaining extension and extensor mechanism function after a quads graft, but it's certainly a promising graft, although at the moment the follow-ups are between medium and short term. Now, we have whole conferences on which techniques to use for ACL reconstruction in the adolescent, and I've put up an infographic here, which perhaps you can study in greater detail in your own time, but I don't really have time here to discuss all the different techniques. Suffice it to say that most surgeons use a transphyseal technique in those patients who are between 13 and 17 years of age. If they're younger, you might use an extraphyseal or even a hybrid type physeal sparing technique. This is the extraphyseal technique, which was proposed by Alan Anderson. I've got to say this is technically difficult, and if you get this 2 or 3 millimeters off, you're actually going to damage the physis much more than a transphyseal technique. So I very rarely use this technique. What we do is take the hamstring tendon graft in these patients who still have open physes. We are plugging that graft in by making tunnels in the bone in the tibia and the femur. The graft is then often suspended with buttons here and here. This is often an 8.5 to 9.5 millimeter graft, and the buttons give you great tension, which gives you a nice stiff, thick graft. This is the intraoperative picture. I always use X-ray to determine the accuracy of the tunnels, to make sure that the tunnels are in the best positions and there's no chance of having to re-drill tunnels. And that's the final picture with the pink showing the physes. You can get gross disturbances if you're not careful. Thank goodness in our Imperial series, we've not had any symptomatic gross disturbances, but that is a real issue. If you get this wrong, the patients go into valgus. As long as you pick it up early, it can be corrected with growth correction surgery. So here is a scheme to think about which type of graft to use, and I would suggest that most of our adolescent patients fall into the transphyseal group, where we use either hamstrings or patella tendon if they're fully mature. Results. There is no doubt that adolescent ACLs have a higher re-rupture rate than adult ACLs, and you can argue many different reasons for this, including a combination of greater laxity in these tissues, perhaps some further non-compliance, perhaps the surgical technique is not so good, but the re-rupture rate, I quote, between 7 and 12% for adolescent ACLs. It is as high in some series as 20%, particularly in the hypermobile patients. Lots and lots of reviews out there. There are some further reviews coming out. I'm reviewing a review at the moment for the journal. But I would point you towards the International Olympic Committee consensus on ACL injuries in pediatrics, as well as our own paper, which we'll be revising very soon. This is our Imperial series. We have a total of 84 patients, mean age 13 years, with a mean follow-up of 5 years. Re-rupture rate is around about 6%, 6 to 8%, and symptomatic instability rate of 3%. Some of them do have a pivot glide, but as I said, the normal side often has a pivot glide with a side-to-side difference in about 5%. In the old technique I was using screws and staples, and often they required removal because they were causing some irritation. With the buttons, much less rate of removal, less than 10% now. Now, what about the lateral tenodesis? This is an operation that we actually helped develop at Imperial in parallel with other groups around the world. Now, this is an old operation, really. You can look into literature. It was actually described by Haygroves, or a version of it, in 1870. And it was performed in the 1980s, but thought to over-constrain the knee. So now we've developed a new version of this, or rather a modified version, using the iliotibial band, which you can see here. It's passed deep to the lateral collateral ligament, and then it's fixed on the tibia, and it seems to help resist pivot and take the strain off the ACL graft. This is how Imperial were involved. Back in 2011, we had an amazing fellow called Alex Dodds who did all the original anatomical dissections, and we were kind of in a race with the Belgian group. We then did the reconstructions with biomechanics in cadavers, and then the anterolateral corner or ALL reconstruction or lateral tenodesis was developed as a modified Lemaire procedure, and those are the papers. And of course, this has been taken up around the world, and there are now, I would say, over 1,000 papers on this. So here's the procedure: lateral incision. You can get this down to about 3 or 4 centimeters. Take a 10 centimeter strip of iliotibial band. Keep it attached just posterior to Gerdy's tubercle on the tibia. Detach it from the proximal end. You then identify a point 10 millimeters proximal and 5 millimeters posterior to the lateral epicondyle. That's what our biomechanical studies suggested was mechanically the most advantageous point. You pass the graft deep to the lateral collateral ligament once you've dissected out the ACL. And then you fix the graft. That fixation can be with a metal staple, a suture staple, or an anchor. We don't have the studies yet to suggest which one's the best one. And you need to fix it between 30 and 60 degrees of flexion with the tibia in neutral rotation. You do not want to over tighten or over constrain the knee. It is more of a check rein rather than a true ligament. That's the scar when you get to a level where you can actually do it fairly minimally. Sometimes the scars are a little bit bigger, but you can get the scar down to that kind of level. There's no doubt that rehab in adults need to be slower. Rehab in adolescents needs to be slower, with the longer time to incorporate with the graft, with a higher risk of re-rupture if they return to play. And you need good quads and hamstring function with good quads and hamstrings match, not mismatch. You then need to check the landing mechanics. You need sport-specific movement pattern check. And remember that they're adolescents. So if I tell an adolescent they can run in a straight line, they're often then run in a pivot, they will kick a ball, and then within a couple of weeks, they'll be back to playing football. So do not forget that they are non-compliant, and everything you tell them, they'll do a little bit more, or possibly even more than that. So in conclusion, there's an increasing incidence of adolescent anterior cruciate ligament injuries. Surgery is better in most patients than conservative management to reduce the re-injury rate. The repair is only for tibial spine avulsions, and repair of the ACL should only be taken part as a clinical trial. Careful surgical technique by an experienced surgeon is required when reconstructing, and there are lots of controversies around surgical techniques, tunnel positions, fixation methods. The transphyseal technique is safe and effective in most adolescents, and the lateral tenodesis is likely to increase stability with a lower re-rupture rate. Thank you very much for listening.
Thanks very much, Tim. Really interesting slides. I love seeing those surgical slides, but they might not be for everybody, but I'm very fond of them. Keep your questions coming in. Don't forget, if you click the thumbs up, the like button, then that tends to bring the question further up for us. And I'll get to them afterwards. There's some really great questions coming in, actually. Looking forward to the discussion at the end of these talks. But now I'm afraid you have more of me. I'm going to give you my kneecap recap all about patella instability in the adolescent athlete. Enjoy. Great. Well, let's get on with the talk. I'm going to talk to you about kneecap recap, all about patellofemoral instability in our adolescent athlete population. This is a problem that particularly affects the growing athlete, as we'll see, and we'll go through some presentations as well as some possible treatment options. So these are objectives I'm hoping to cover. Who's going to dislocate? How might we predict it? How we manage acute instability, something you might come across in your practices on a reasonably frequent basis. And then once we've managed the acute instability, who might need more and what might that look like? So who dislocates? Well, there are sort of two groups of patients here. You can imagine a normal joint exposed to very abnormal loads. So this might be an acute dislocation. Somebody's tackled playing rugby, hits the ground, kneecap first, and it gets pushed out of the joint. It's reasonably unusual, but certainly we do come across those occasionally. More commonly, it's a joint that's got intrinsic problems, which is exposed to normal load. So a simple twist pivoting usually with the foot planted, pivoting in the opposite direction. So a right knee planted, pivoting to the left. That will give an external rotation relatively to the tibia and pull the patella out of joint rather than it being pushed. So if you take a careful history, you'll often be able to differentiate between these two different presentations. The reason it's fairly important is that the second group, those who've got an underlying joint abnormality, are of course more likely to redislocate. I would say the vast majority of patients who make it to me have got an underlying anatomical problem that we often need to address. So the patients, what do they look like? Well, most of them have their first dislocation in their second decade. So this is as our patients grow, they get stronger, they get heavier, and so they put more load on a joint. And if it's got intrinsic weakness, then that's going to be exposed. The highest incidence of first dislocation is 10 to 15-year-old female adolescents. So this particularly is when you can imagine people are getting into sport in a more serious way that can really lead to problems arising. So the acute phase, as the knee is swollen now, the presentation is fairly typical. Often the patella will relocate spontaneously. If it doesn't and it's stuck out laterally, then usually extending the knee will allow it to pop back into joint. You need to be a little bit careful as you do that and coax the patient into extending their knee because they don't usually want to move it very much. And then once the patella's back in joint, we're going to treat that with the usual recipe of ice, elevation, rest and compression. We're going to regain range of motion in the early phase, and often there's quite significant and profound quads inhibition through the hemarthrosis that develops, and you need to support the knee and perhaps support the patient with crutches during that period. I wouldn't normally brace an extension, so that's something we're really moving away from. You might want, once the acute phase is starting to settle, a brace a little bit like that one to help the patella to track a little bit more centrally and give patients more of a feeling of control. The only real exception to going through the non-operative and conservative route during this acute phase is if someone has a significant osteochondral injury with a big hemarthrosis. So if you're suspecting that, then that's where imaging comes in, and really you want an MRI scan if the knee is really very swollen and you're suspecting an osteochondral injury. Why? Because we might need to put those back sometimes. One of the things I tend to speak to my patients about whilst they're going through investigations is about limb positioning, and I tell them to keep their foot pointing in the same direction as the rest of them. In other words, not to pivot on that limb, and that helps to reduce some of those instability episodes. And of course, there's a role for non-operative management with quads training in addition. So recurrent dislocation is a slightly different kettle of fish. Really here what we need to do is diagnose the underlying anatomical problem and fix it. So this is what I would term a la carte surgery. If you find a problem, you try to address it in order to stabilize the joint. There are some very good guidelines that we've developed at the British Patellofemoral Society in association with BASC and the BOA, which explain quite nicely how we put patients through a particular algorithm whilst investigating and treating for recurrent patella dislocation. And so the diagnosis is just as we've spoken about, really, history, and then some diagnostic criteria. Don't forget to look for generalized hypermobility, which is another risk factor for recurrent dislocation. And then radiographs. We do get x-rays in these patients. They are useful. It's not just an MRI analysis. The x-rays are useful for looking for chunks of bone that have been knocked off in the acute phase, but also you can start to characterize the trochlea, so the femoral groove down which the patella runs. So abnormalities of the trochlea are often seen with this type of instability problem. I would say an MRI scan is now pretty standard, though, and we're looking for the cartilage, but we're also looking at the various points of morphology of the patellofemoral joint, fairly well listed there. So what's the usual anatomy that we find? Well, you can think about this in terms of the patella, the femur, or the tibia, and of course the relationships between all three. Patella height is important. Why? Well, even if you've got a normal trochlear groove, if your patella is very high, then the knee will be considerably flexed before the patella engages that groove, which means that it has a side-to-side mobility throughout the early range of flexion, making it more liable to take the wrong route and go out laterally and escape the groove altogether, dislocating. And so we can measure this on radiographs, and there are different methods of doing it. Each have their pros and cons. And this is the type of patient we're looking at here. And by and large, what we're looking to do is measure the relationship between the patella and the distance often from the tibia. Now, that's sort of an indirect measure of what we're really interested in, which is the relationship between the patella and the trochlear groove. And so this is perhaps a better way of looking at that, which is the patella trochlear index. You're looking at how much overlap there is between the patella cartilage and the trochlear cartilage, and we usually look for about a third. So in this patient, this is the same one as that radiograph we saw, we can see the patella articular facet is 32 millimeters long. It's not in any contact with the trochlear groove here, and so if we were to have a normal overlap between those two, the patella should really be about 10 millimeters more distal, and I hope you can all see how high up that patella is. There it is, 32 millimeters. We also want to look at patella glide in our patients. So hypermobile patients will have more glide than is normal in inverted commas, but also this gives you an idea of the integrity of the medial patellofemoral ligament. I would say unless they have quite considerable joint hypermobility, the MPFL is always ruptured at that first dislocation, and that means that it's easier to subsequently redislocate. It's one of the reasons we run into these problems with recurrent dislocation. So compare one side to the other. Hopefully it's not a bilateral problem. Next is to look at the femur once we've considered the patella, and so rotational profile can be important here. We usually assess this clinically, but if in doubt, a CT scan looking at the hip, the knee and the ankle will help you to look for rotational issues, so axial deformities that may lead to an abnormality between the relationship between the trochlear position and the patella. And so the trochlear can vary according to its position. And you can see here the typical squinting patellae that we see with anteverted femoral necks and compensatory internal rotation of the femur. And that will, of course, medialize the trochlear, mean that it's more likely for the patella to run laterally. But the shape is really a very important determinant of stability. And so what we really want to see is a nice deep trochlear groove, like you can see in these images, because that's going to allow the patella with a reciprocal shape on the undersurface to run up and down with good stability. And so the shape can be characterized according to this classification, which is useful, and it's based on a lateral radiographic appearance. I have to say, once again, I think MRI is a better way of doing this. And so here we just characterize it according to whether the trochlear is concave, as it should be, flat, often seen in dislocators, or in the worst cases, convex. So as in here, you've got actually a rounded trochlear. There is a little groove, but it's nowhere near where the patella is, and so it's got no chance of being captured by it. Next is the tibia, and so the offset between the insertion of the patella tendon, the tibial tuberosity, and the trochlear groove can give you an idea of what the lateralizing vector is when the quads contracts. So if the quads contracts here, you can see that line drawn there, the Q angle, if you will. It wants to straighten, and therefore you're developing a lateralizing vector, a force which pulls the patella out of the joint. And the further across the tibial tuberosity is, the greater the magnitude of that force. So we can look a little bit at this and deduce it from looking at the patella tracking. You can see here a video of a patient with reasonably marked J tracking. The patella escapes laterally in full extension there. That's the J tracking we're looking at there. But we can also measure it on imaging here. This is axial imaging, and we can look at the position of the trochlear groove in comparison to the tip of the tibial tuberosity and measure the horizontal distance between the two, and that gives us an idea of how large that lateralizing vector is. So the patellofemoral joint is a pretty complex joint, as I think I've probably illustrated there, and so its stability is going to depend on the bony chondral congruence, so how well it all fits together, also the muscle pull, as we've seen, and then the integrity of stabilizers such as the medial patellofemoral ligament. And so there are some risk factors for redislocation, and you should probably know these if you're dealing with a first-time dislocator. And if you've got a flat trochlea, if your patella is high, or if you're skeletally immature at the time of your first dislocation, then those are the rates of redislocation. If you've got all three of those risk factors, then you're looking at an 80% redislocation rate, pretty high. And so when we have this recurrent dislocation, that's when we're going to look to maybe intervene with some stabilization. The first one, and in my view, one of the most successful ways to deal with this is this. So here's our patella alta patient. You can see how high the patella is there in relation to the femur. And all we want to really do is slide it down a little bit so it engages the groove at an earlier part of the flexion cycle. And we're going to do that here by performing a tibial tuberosity osteotomy. We've removed or cut, liberated that shingle of bone from the front of the tibia to which the patella tendon's attached, and simply distalize it, pulling the patella down into that new position. And you can see there it's going to engage the trochlear groove much earlier through the flexion cycle. And it's really successful surgery, this, and it's very gratifying because you can see here from arthroscopic images on the left, this is my arthroscope sitting above the patella looking at it in the pre-stabilization state. You can see how it's going laterally there and falling out of the joint. And then we can go on to the post-stabilization state and how beautifully that glides straight down the middle of the joint. Same patient, pre and post-stabilization. And you can see how that patella really is going to be much more stable, much less likely to fall out of the joint as a result. Slightly sort of more open surgery, if you will, rather than the arthroscopic stabilizations, need to be considered when somebody's got significant trochlear dysplasia. Here you can see a bump on the top of the trochlea, and what we can do is deepen that by taking the bump away. So you can see the contour on the left, the contour on the right. We've really changed that a great deal, and so the patella is now going to be better captured by the trochlea. Open surgery, not to be undertaken lightly, complex surgery to do as well. And so here's a case of a patient who's, you can see there, quite significant trochlear dysplasia, patella that's dislocated, just with the knee out straight. And if we look at them intraoperatively, this is when they're asleep before we've made an incision. There's the flexion extension, and you can see what happens with just a slight lateralization, patella simply dislocates. So we're going to deepen that groove. There's the trochleoplasty that's being carried out with a tape holding down the new groove in position, and then we can check that again post-operatively once we've done that to see what happens. You can see the patella now stabilized, sitting in the groove very nicely, and even with a big clumsy orthopedic thumb on it, it's not moving out. And medial patellar-femoral ligament reconstruction is also a very nice way to stabilize the less dysplastic knees, the less dysplastic trochlea, where the patella isn't too far out. That's just simply a ligament reconstruction to hold the patella in position. So in summary, look, if we're dealing with early first-time dislocators, then I think the most important thing to say is to get early weight bearing and to get our patients bending their knees as soon as possible. Look for that osteochondral injury. The clues are a big hemarthrosis, and if you get radiographs to ensure the patella's back in position, you can sometimes see a bony flake that's been avulsed somewhere. That should prompt an MRI scan and consideration of early fixation. But if you've got a recurrent dislocator, then really you do need to think about the different ways that you can stabilize the patella. And I think return to sports after this is actually pretty successful, believe it or not. It takes time. It probably takes 6 to 9 months. It's no less an intervention than something like an ACL reconstruction, but it is very successful in those patients who undergo it with very low redislocation rates, depending on some of their other risk factors, of course, in their particular sports. But I have to say I've had pretty good results in our adolescent populations at getting a return to sport for them. So thank you for listening. I would urge, if you want to hear more about the patellofemoral joint, it is a fascinating joint after all, to consider joining us at the British Patellofemoral Society. We'd be very welcome and be able to talk about similar topics with like-minded people. But thank you for your attention. Great. Well, I hope you enjoyed that. I can see from the questions coming in that, in particular, the idea of rest, ice, and compression not being favoured by all. So we'll get to that in the questions at the end. Of course, we will. But thank you for listening for that talk. We've got a couple more to go before we get to the questions. And next up, we've got another surgeon. My colleague Ricci Plastow. So he's going to talk to us about hip and groin pain in adolescence. So over to Ricci.
Hi, everyone. Thank you for the introduction. My name is Ricci Plastow. I'm going to be discussing hip and groin pain in the adolescent athlete. So first of all, we have to talk about the fact that during puberty, the adolescent athlete will be at high rates of injury due to the muscle strength being lacking for the size after puberty growth. There's also overload injuries due to the increasing level and demand of sport placed upon an adolescent. We have to consider the different anatomy of the pelvis. There is many apophyses attached to major tendons used in sport, and that inherent weakness can fracture or cause pain. Differences between the men and women's pelvis and the inguinal canal can cause different types of problems. So the aims of the session are really to define that exact pathology with classification, look at the specific apophyseal injuries and some case scenarios, and also mention chronic groin pain syndrome in the adolescent athlete. So first thing to do is really classify the problem. So we use the Doha agreement to look at the different entities. You can see here that they classified 3 different types, looking at groin pain and subspecifying adductor related, iliopsoas inguinal related, and pubic related groin pain, and then defining hip related groin pain and other causes. There sometimes can be crossover between these different diagnoses, but it allows you to reduce the number of potential diagnoses in different areas. So how do we define where exactly the problem is? Examination is key, as always. We need to look at the specific tests for each area, such as adductor-related pain with Copenhagen squeeze test and resistance testing. Within the inguinal canal, we have to look for posterior wall bulging, scrotal invagination in the male with Valsalva maneuver, and also look at hip range of movement and special tests such as Fadir and Faber tests. Going on to the unique anatomy, we know there's lots of apophyses and secondary growth centers around the pelvis, as you can see here in the diagram. That forceful concentric muscle contraction on that inherently weak area during adolescence is a problem, and we can see avulsion fractures. They're still misinterpreted as muscle strains, and so imaging is essential to confirm the diagnosis. Historically, we treat them non-operatively, but actually there are complications that can occur, such as non-union heterotropic ossification. And with this, that can cause functional problems with the hip joint itself and also nerve-related pain. Going on to apophyseal injuries and looking at the literature, the most prevalent one we see is of the anterior inferior iliac spine. And this seems to be due to kicking sports with the rectus femoris attaching to that area. Misdiagnosis and mistreatment can delay return to sport, and that's a really big problem in the adolescent athlete as they're really trying to progress through the ranks to the adult level. It can cause longer-term performance problems and even growth arrest. Materna et al. Looked at a large series and found that the majority of these physeal problems are in the hip and pelvis. And you can see as the age groups get older, the amount of days lost per squad are much higher in the under 16s, and that the pelvis apophyseal injuries are the highest burden in the under 17s age group. So non-operative versus operative for the avulsion fractures. Well, in the largest series seen here from Eberbach et al., conservative treatment was still the mainstay, as we expect, 89%. But we do see with surgical treatment that the period of partial weight bearing is sometimes a little bit less, and the return to sport can be slightly less as well. When you actually scrutinize the data a bit more between non-operative and operative, you can see the success rate in patient-reported outcomes is higher in the surgical patients. And the return to sport is also higher at 92%. Return to sport timing is less with surgical repair, as you can be more confident in the rehabilitation phase. The other important point is displacement seemed to be a significant factor in when to perform surgery. So displacement more than 15 millimeters was significant in the recovery and in the end outcome. 84% had an excellent result with surgery in that group, and only 50% of the non-operative patients had a good outcome. So that's a significant factor, and we have to take fracture displacement into account, but also the physical demands of the athlete in that decision-making process. So looking at those complications, very similar between the groups, but actually different types of complications. So heterotopic ossification is higher in the surgical group, and it seems to be due to that trauma and fixation of the avulsion fracture, creating excessive bone. The neurological complications were similar, but obviously non-union rates were higher in the conservative group. So it's a balance between heterotopic ossification and non-union in the two groups. We have tried to counteract that with reducing the high heterotopic ossification risk with actual resection of the bony fragment, and then high dose naproxen for 4 weeks. And we've reduced our HO rate significantly to below 2%. When you take that into account, then actually the complication rates are significantly different in favor of surgery for displaced fragments. Going on to hypertrophic union. So this can happen, and it's more common in the anterior inferior iliac spine avulsion. Wheeler et al. Showed a 14% rate of hypertrophic union needing surgery due to hip impingement. You can see from the imaging here that even with CT scan, that subspine impingement is a problem when the hip is flexed. And so that is quite a common complication from non-operative treatment of these types of fractures. So what do we do for these rectus femoris avulsions? Well, undisplaced obviously gets treated non-operatively with analgesia and immobilization of that muscle group. But displaced fractures, even over 5 millimeters, we have to have a discussion with an elite level athlete about the risks of non-union or hypertrophic union in that area. It's 5 times more likely to develop chronic pain, and we tell the athlete that. And then they can make an educated and decision on whether they'd like to go ahead with surgery or continue on the non-operative route. The heterotopic ossification is still there, but it's much lower than the reported literature because of removing that bony fragment and tenodesing to the surrounding muscles to offload the repair. We give naproxen and omeprazole to reduce the side effects of the anti-inflammatory. Now moving on to hamstring avulsions with the ischial tuberosity apophysis. So Nauta et al. In the largest study also looked at this 1.5 centimeter displacement as the deciding factor for surgery. They found fantastic return to sport in both groups if you classified with that displacement amount. Non-union was significantly higher, 18% in the conservative group. So you have to speak to your patient about that significant non-union rate, and they then can consider the risks of surgery versus that non-union rate and delay to return to sport. Also, the risk of recurrent injury. If it doesn't heal with significant callus, then there's going to be a risk of recurrent injury early on. And the return to sport is with early surgery is 100%, whereas it was only 90% with delayed surgery. So early intervention is needed, and that comes down to early diagnosis. So looking at the apophyseal avulsion, again, undisplaced fractures are treated non-operatively. But if they are displaced, we need to have a discussion about the risks of non-union and hypertrophic union. This can cause ischiofemoral impingement and sciatic nerve symptoms in the adolescent athlete trying to go back to sport. Most people have used screw fixation, but unfortunately they cause pain, ongoing pain post-operatively, and usually need removal at a later date. So we now resect the bony fragment and use bone anchors instead of screw fixation. This seems to have reduced the heterotopic ossification risk, and that is why we are using that technique. Here's an example of a 15-year-old male rugby player, 1 year of misdiagnosis. It was put down as a hamstring strain, and the imaging only came later. But you can see from the X-ray here, heterotopic ossification, significant displacement, and causing sciatic nerve symptoms. There was over 5 centimeters of retraction. The MRI scan here is showing the blue star. The red circle is showing the bony fragment. The blue star is showing the scar tissue, and the yellow star showing the sciatic nerve in its close proximity. We were able to resect that fragment and repair the tendon back with bone anchors and place them in a brace for 4 to 6 weeks and slowly stretch out the hamstring back to its normal length. After that, we do have to exclude any hip-related pain. Here are all the causes that you have to look at, and the MRI scan will pick up these diagnoses. So essential to get that imaging. You can see some imaging here of dysplastic hips, which can cause this type of problem in the adolescent athlete. Going on to the more chronic problem around the sports groin pain syndrome. It's mainly seen in the football player and the male football player. It's usually an overload injury as they're increasing their height and mass due to puberty. Their muscle strength has not quite caught up, and they decrease their flexibility, causing excessive force on the pelvic region. They also have an increasing gain volume and intensity at this age, and that's why we see a high rate of injury in football players compared to adults through the literature. That imbalance between the rectus and oblique muscles versus the adductors and pubic symphysis causes that instability and pubic bone edema. Rehabilitation still is the mainstay of treatment for this adolescent population. So looking at the specific anatomy of the inguinal canal is important. You can see here that the posterior wall with the conjoined tendon is where potentially there can be a weakness, and that is potentially where herniation can occur in the male, and in female that there can be a femoral hernia. This complex anatomy allows us to look at pathologies such as sportsman groin and athletic pubalgia and try to define which one is causing the problem. The difference in anatomy between women and men with the increased pelvic bone angle in women allows to offload the adductors, and that's why it's not as big a problem in females compared to the male. Also, the round ligament is smaller than the spermatic cord, meaning less weakness in the muscles. You can see from this diagram that the femoral hernia is in a slightly different pace to the direct and indirect hernia, which is higher in females than males. Looking at the plaque anatomy, this is important for adductor injuries. And again, images is essential to look at this area and the fibrocartilage. That MRI imaging needs to be very specific, and this paper highlights the views that you need. Looking at adolescent groin pain, we feel that there's potential damage to the adductor and to the fibrocartilage that attaches to the abdominal muscles. This then scars and prevents an imbalance between the muscles. And that's what we're looking for. If we get early imaging, we will see it, but later on, it's not as clear. So early imaging is essential. Here's some MRI pictures picking up the bone edema in the pubic bone in different views, and also some adductor inflammation and signal. The delayed presentation hides this adductor injury usually, and we also need dynamic ultrasound to exclude any inguinal disruption. The mainstay is still rehabilitation for this, but surgical options are available if there is ongoing pain despite rehab. Looking at the surgery for this chronic sports groin pain, we usually have a general surgeon present to expose the spermatic cord and place mesh repair on the posterior wall if needed. And then we explore the adductor and repair with bone anchors. We do not perform adductor tenotomy as most surgeons do, because we feel this reduces adductor strength in the athlete and performance. We should be repairing the fibrocartilage and restoring that anatomy back to the rectus and the abdominal muscles, and that's key for us. There are other causes of groin pain that you have to exclude, and this is a list of them. And so in conclusion, correct and timely diagnosis is essential to the hip and groin pain pathologies. We need x-rays of that area rather than assuming it's a muscle strain, and MRI if you're worried about groin pain syndrome. We believe significant displacement over 5 millimeters warrants further imaging and discussion around surgery in the elite level athlete. That is due to the risks from non-operative treatment, such as hypertrophic union and non-union. There is a risk of heterotopic ossification with surgery, but we have reduced that significantly with our technique. And also chronic groin pain syndrome is rare in adolescents, and we usually treat it non-operatively, but rarely adductor repair and inguinal wall reinforcement is needed. Thank you. Any questions?
Thank you, Ricci. Fascinating talk on athlete's groin. So much anatomy there. A lot to take in, I think. So we'll welcome your questions as ever. We have one more talk for you before we get on to the Q&A. And this is from Professor Marco Cardinale, who's going to talk to us about protecting young athletes, performance progressions, injury prevention, and realistic expectations. Thank you.
Thank you for the very kind introduction. I've been asked to talk about the topic of protecting young athletes, some aspects of performance progression, injury prevention, and realistic expectations. I will talk about growth and maturation considerations, so I'll give you a bit of an insight into these aspects. We will talk about performance progression, so I hope you get an understanding of how we look at athletes progressing in youth categories, some of the issues we face in youth sports, and hopefully in the end some summary and conclusions. I think it's very important to start with the concept that youth athletes are not mini adults. We hear that all the time. We need to make sure that we understand that youth athlete development, it's a very individual and unique and constantly changing base of normal physical growth, biological maturation, and behavioral development. It's very important to know the development stages and understand how to implement appropriate coaching strategies, but also understand what are the consequences of somebody growing on their performance. I hope that I will convince you at the end of this talk that success at very early stages does not guarantee success at very senior level, but it's important to understand that and recognize it. And also that many times, unfortunately, selection and deselection criteria tend to favor early maturers in most sports, and then we will explore that. And the final thing is they are not really adults. We keep saying that, but they're not. The other thing that is very important to recognize is that the journey from the bottle to the medal as an adult is never a linear one. There's lots of changes of directions and issues that happen over the growth of a very young athlete. So it's very important to always understand the context of changes to really make informed decisions, not only on the coaching elements, but also on the reduction of injuries, prevention of injuries. It's also important to recognize that we're talking about different people here. This is a bunch of kids that are playing sports. That's a completely different story from somebody that is relatively good at sports and ends up playing in all the school teams and all the teams he or she wants to play in, and is engaged sometimes in sports activities that can be 10 to 18 hours between school sport and organized sport, to the extreme of the elite young athlete, which is a child who has superior athletic talent, undergoes specialized training, receives expert coaching, and is exposed to early competition as per definition of the IOC. And these are kids that can train a lot of hours. So Simone Biles at 14 years of age was training 32 hours a week to win all the medals that she won at the world level. Tom Daley was the youngest team member when I was with Team GB in Beijing 2008, was only 14 years of age and was training quite a lot more. So I think we need to really diversify the recommendations and the ideas we implement between children that take part in sport to children that are actively engaged in sport to the elite young athlete. I think there is 3 different categories here that we really need to take into account. So everybody talks about the development of athletes. We know that at a very early stage, we engage them in sport and they learn to train. Then towards adolescence, they train to train and begin to compete. Then as juniors, they train to compete, and as seniors, they train to win. But the reality nowadays is not only that somebody enters an academy like this at 12 years of age and exits as an Asian champion in this particular case, but we have performers that are actually performing on the world stage as senior athletes in the age where they are supposed to be learning to train or training to train. So these are 2 examples of a young medalist for Team GB that was 13 years of age at the time she won a medal at the Olympics, and a football player that plays a final of a major championship that is below 18 years of age, so technically not even capable of driving to his training ground. So I think we need to rethink that when we look at the elite element of athletes. And when we talk about young athletes, we talk about age, but we should consider other aspects. So first, age is the age of chronological age, is the age of the person with regards to the year since birth. We need to also know training age, which is a number of years the young athlete has spent performing structured formal training, and biological age, which is the stage in which the young athlete is at. So when we are implementing strategies to train, develop, reduce injuries, we really need to know these 3 main things. What's their age, what's their training age, and what's their biological age. But age is only one piece of the puzzle. We need to know the growth status because we want to know how much the athlete is growing, and we want to know their biological age too. So one way of doing that is to use skeletal age, which is measured with hand X-rays, and also understanding and assessing the secondary sexual and somatic characteristics, as well as dental age. And then maturity timing, which can be measured with simple anthropometric measures. And they tell us the age at peak height velocity, or how far the young athlete is from reaching peak height velocity. And peak height velocity is the period of time in which an adolescent experiences the fastest upward growth in stature. You can see here from the peak, and you can see that both males and females reach the peak height velocity at different stages of their growth, but also there is a large variability between individuals. These are different percentiles. So we have individuals that reach peak height velocity at an early stage in their development, and people that reach the peak height velocity later. So the definition and the determination of those stages is important to understand where the child is in terms of their growth and maturation. The skeletal bone age methods involve the assessment through an X-ray of the hand, of the bones of the hand and the forearm. There are different approaches to that. Historically, all these approaches have been developed in the past. It's based on very old databases, and it's based mostly on Caucasian children. And therefore, we need to take this into account when we're actually defining the bone age and the skeletal age of an individual. The most used ones are here on the left, the Tanner-Whitehouse, which evolved from the Oxford method, the Grulich and Pyle method, which is based on a radiographic database of 1,000 children in the 40s and 50s, the Fels method developed by Roche, and the Bailey-Pinot, and that also provides the adult height prediction. Recently, Malina advocated the use of the Tanner-Whitehouse 2 method rather than the 3 because of the systematic lowering of skeletal ages and some negative consequences during maturational assessment. We had experience of that in the Middle East, and we used the Tanner-Whitehouse 2, TW2, as the most accurate method for determining adult age. And so it's very specific to the population you're going to measure it with. The radiation exposure is very small, but you still need an X-ray, and you really need either expertise in reading those scans, or nowadays with some artificial intelligence methods, you can use AI to detect skeletal age. And in recent times, there's been technology developments suggesting the use of ultrasounds, which are no radiation, portable, can be used in different fields, but the validity and the specificity of those measurements in different populations is still undergoing a lot of validation. And so you need to be aware of those limitations if you use those methods. Why is this relevant? It is very relevant. This is an example from the work of James Baker, doing a PhD at the moment on this topic. You can see that in his group that he was training, if you measure the maturation status, you have athletes that have a chronological age range difference of plus minus 1.8 years between each other. This is their chronological age in black. If you measure the skeletal age, you have a child that is in the skeletal age between 17.5 years, but his biological chronological age is 12.6. And then they are in different stages of maturation according to how far they are from reaching peak height velocity. So within a small group of kids that has a very small difference in chronological age, you have a large difference in skeletal age and a relatively large difference in maturational status. And anybody that works in young sports, in youth sports, can see this is the type of things you see around adolescents, and it's true in boys and girls. So you need to understand where the athlete is at, but what you really want is to understand performance. So we measure a variety of things, but nowadays there is performance data that are available in public, and you can measure the performance of people in different competitions, in different sports, and that can help you understand the dimensions of how people normally evolve, how young athletes progress, and also allows you to analyze the potential, get the benchmarks, and identify unusual performances. So we started looking into this many years ago with Italian athletes in jumping. And what we found here, every individual line is an individual athlete from the age 12 to until they retire. And what we found, of course, that the rate of development is really important, because the rate of development tells you who has the chances to progress later. But the most important finding on this initial database of more 6,000 athletes analyzed showed that the percentage of athletes that was top level as seniors, and there were not many that were top levels as juniors. So the fact that you are top level in junior, it doesn't mean that it's going to translate as a top level as a senior. But the most important finding was this idea that we had, that we think that athletes that reach success at senior level are the ones that develop the most. Might not be the ones that look the best when they are measured at a very young age, but are the ones that develop the most. And you can see here that the rate of change in this database of athletes that reached the top later was always higher than the ones of the athletes that were at the top of the ranking when they were young. We validated this finding in a large world database, and we measured more than 40,000 athletes in the last few years. But this is what we found in different events. In jumping events, only 8% of males and 16 females that were ranked top 50 at the age of 16 were confirmed as seniors. Pretty much the same numbers in the different events. So from distance running to throwing to sprinting event was pretty much the same. But the most important finding is this. Again, the rate of improvement of athletes that made the top 50 as seniors was always higher than the athletes that didn't reach the top level as seniors. So they tended to not develop in performance after the age of 17 or 18. And we've seen that in men and women. We've seen that in different competitions. These are examples in jumping and sprinting event. We saw exactly the same in middle distance, when many athletes that are in the top 50 as juniors or youth do not translate in reaching the top as seniors, and very few transfer to other middle or long distance events. And this is the same for boys and girls, for men and women. So the chances of translating and becoming top 50 as a senior if you've been top 50 as a junior are very slim. We validated that as well with swimming, and we saw exactly the same behaviors, that very few swimmers that are in the top 50 or the top 10 as juniors translate into top 50 or top 10 as seniors. Again, we see exactly the same thing here. So the kids that were only good at junior in the top 50, they stop developing, and their rate of performance or performance time, it doesn't change. You can see here and here. Whether the kids that were not in the top 50 as juniors, but became top 50 as seniors, had a faster rate of development and a better improvement over time. So the rate of development and improvement is really a marker of your chances to becoming top as a senior. In team sports, we've seen exactly the same. In the Italian national teams, in both men and women, We have seen that very few that are selected in the youth national teams translate to senior national teams, and many that are selected in youth national teams actually disappear from national teams, with a strong bias towards selection of boys and girls born in the quartile 1. Boys and girls do get injured. This is the first study we did in youth athletics here in Qatar. They tend to get injured when they start growing. So knowing growth and maturation should be a sign for you to change your training program because they are at risk of getting injured, especially when they change in length, and they start to change their growth. And injuries are really sport specific. So this is, again, the cohort of track and field athletes in a full-time academy. And you can see that the pattern of injury is very different between the non-specialized athletes, the overall group, as compared to the endurance, where you have a high bone stress injuries incidence, as compared to the jumps that have muscle strains, to the throws that have muscle strains and tear, and the sprints that tend to have more muscle strains and tear, with virtually no muscle strains and tears in the endurance group. So really the endurance, the sport specialization determines the specialization of injuries too. So training should take that into account, and protecting the athletes comes from knowing what is likely to happen in their development. So many athletes probably don't transition from junior to senior because of the injuries and because of the wrong training loads that are applied to them. Finally, an issue that is age fraud is very well reported in different sports in different parts of the world, and understanding skeletal age and growth and maturation can be important to identify those, but also making sure that we don't put children at risk of competing with children that are actually older than them, and in many cases they are not actually children. So it's a topic that requires a lot of discussion and conversation around it. So in summary, early success is not a prerequisite for success at adult age. We need to assess maturity status. Health and longevity in the sport is very important. We really need to change our thinking in terms of training and competition exposure. We need to understand injury patterns, and we're mindful that early talent might be more at risk because they might be exposed to more competitions. And coach and parent education is really key. So thank you for your attention. I would like to acknowledge all the colleagues that work with me on these different projects from Aspire Academy and my colleagues in Italy. And finally, this is some free reading resources that we have created on the Aspetar Sports Medicine Journal. Thank you for your attention.
Brilliant. So there we go. Those are our talks for this evening. A huge amount of information, and it's stimulated a lot of interest. I can see that from the questions in the Slido. Thank you for both putting your questions in and also voting them up so that we know which ones to address first. And keep putting them in there. Of course, if we don't get a chance to get them tonight, then ISEH endeavours to answer those on socials throughout the coming week. So why don't we jump straight in? And one of the first questions that was asked, in fact, and also one of the most popular ones, I'm going to ask Marco, if that's all right, Marco. There's a question here. What's the right age for a child to start sports?
It depends, of course, on what we mean by sport in organized, structured manner. I think we should start with children as soon as possible to do physical activity in general, keep them active, develop motor skills from a very, very early age, and then introduce them to structured sport, probably around the age of 5 to 6 when they enter primary schools. What is very important also to know is that we should expose them to as many sports as possible. So early specialization is actually not recommended, apart from very, very few sports like gymnastics, where success tends to happen at a very early age. Effectively, every other sport doesn't need specialization. The problem with specialization is that they might get burned out later on, but also they might develop specific injuries because they limit their development of motor skills. So my advice to parents out there is that engage your kids in sports and physical activity at a very early age. Make sure they experience different sports, probably at the same time, from time to time, until they actually decide where their passion lies and where they want to dedicate the full effort if they are trying to achieve something at competitive level. But even if they want to keep engaging in sports, just have the variety is very important at a very early age. So do not early specialize. That's bad news.
That's a fantastic answer. Thank you. And generally, sport is good, right? I've got 3 boys at home, and you can't stop them playing sport, quite frankly. But on that note, and just to perhaps finish on this, if that's all right, what are your views on teenagers training, specifically weightlifting in the gym? A great question from Sanal.
Yeah, it's there's been a lot of fear around weightlifting in kids. Actually, there's nothing wrong with it. In fact, weightlifting is probably one of the safest sports to do in terms of the injuries. Of course, what is wrong is if excessive load is utilized, if the techniques of lifting are not thought properly, then that puts anybody at risk. So not only the adolescents or the children, pre-adolescents, but also adults. If you don't know how to lift properly, you are at risk. So we now see in youth academies. We have that in Aspire Academy, for example. We start introducing weightlifting at a very early age. And of course, we do it by teaching the techniques first, and then applying appropriate loading depending on the age and the growth and maturation status of the individual child we have in front of us. So there's actually nothing wrong with it. Actually, in many other sports, the loading is a lot higher than just lifting weights, and puts the athletes more at risks. If we think about plyometrics or jumping down from big heights or doing triple jumping, there's a lot more loading that goes through the spine and the knees than actually squatting a little barbell. So I think it's important to start at a very early age, but you need to have appropriate coaching and appropriate development.
So safe in the right environment. Thank you so much.
In the right environment.
Lovely. Well, look, moving on from that, there's a question that's now top of the pile. I can see that my slide with Rice on it has provoked furore out there. Noel, can I ask you, there's a question here. What are your thoughts on peace and love versus Rice?
Thanks, Sam, and great question. Yeah, so this, for people who are not aware of peace and love, I hope you achieve it in 2025, but this is the evolution of the RICE acronym. Initially went to police, was the next thing that was published, which was a transition away from rest, which I think was a really helpful transition, in that there are very few sports injuries that improve with rest, and optimal loading, which came into the police acronym, I think is key in injury management. The next publication was on the peace and love acronym, and I think as this tends to extend, it loses impact as people cannot remember the letters, and things get shoehorned in order to create an acronym. So some of the principles within there, I think, are helpful. I think load being within that is really helpful. I think that should be really the key message. I like that avoiding non-steroidal anti-inflammatories is there as a general advice. I think there are some conditions, as I mentioned in my talk, that are helpful, or can be helpful. I think it's useful to kind of to flag up some concern about the use of anti-inflammatories. Education is in there, which I think is absolutely the cornerstone of management of all injuries, really. In the particular acronym that was published, education includes your body knows best and avoid medical investigations, which I don't agree is good advice generally in injury management. And I think seeking the correct diagnosis and having a structured plan is something that will give better outcomes and results in general. So yes, I'm pleased to see that RICE, we're moving away from RICE, we're moving away from rest, and we're moving away from ICE and the blanket application of ICE consistently in injury management. You know, sometimes for weeks and months, people are still applying ICE to injuries, which I think in general is not helping recovery of tissue.
Thank you, Noel. A very comprehensive answer. But from sort of those principles of first aid and non-operative management to perhaps more complex interventions. Chim, there's a question here. Would you always do surgery for an adolescent ACL rupture, or is there any evidence for bracing, cross-bracing specifically in this age group?
Yeah, I definitely not always do surgery, and that's if it came across that way, I apologize. I think you've got to really equip the patient, but particularly their parents, with all the knowledge. And there are so many factors here at play. So we've mentioned hypermobility. We need to talk about not just ACL, but what other structures are involved, in particular the meniscus, perhaps the MCL, and certainly other ligaments like the posterolateral corner. But if the meniscus is damaged, then I think there's no doubt that surgeries to stabilize the ACL and meniscus repair is desirable, and it results in less re-injury, although that re-injury rate is not zero. So I think, I mean, I had someone in my clinic last week, and I said, look, there is a choice here. This is not a must do, and the surgeon should not tell you what to do. But the risks of re-injury are higher if we don't repair. If we don't reconstruct or operate, but they are not zero if we do operate. So you can then start educatedly guessing what the re-injury rate is, and that's very different for each player and the sport that they play and their overall individual biomechanics. Now, cross bracing is an interesting one. I think the studies are short to medium term. I am not sure adolescents will comply with a 90-degree brace for very long. I'm not sure there's a lot of evidence out there for compliance. I mean, brace compliance is bad enough as it is, so it's not something I would recommend in adolescent.
Okay, very clear. Thank you very much. Perhaps staying on a surgical theme for a moment, Ricky, there's a question here. I think it probably came up in Noel's talk, actually, but I think you're probably well placed to answer it. I think it's about displacement of the ASIS type fractures. Have you got, I know you covered it in your talk, but have you got criteria as to which of those do well non-operatively and which might require intervention?
Yes, well, in the studies, it certainly seems to be highlighting 1.5 centimeters, and that's probably the most striking figure or number that's been used. We actually look at less than that, depending on the athlete and the level that they're performing at, because it really comes down to non-union rates versus the other risks of surgery. So things like heterotopic ossification, nerve injury, risk of infection, those types of complications from surgery. Now, if it's significantly displaced over a centimeter or 1.5 centimeters, the risk of non-union is very high, and the literature suggests it's anywhere from 10 to 20%. So you have to have that discussion with the patient and the parents, saying that we could be 6 months down the line still not playing sports, still in pain, and that's where the sort of trigger for potential surgery comes from.
Very clear. Thank you. Rick, there's a question here for you, actually. You mentioned a couple of conditions in your talk, and there's a question here. What sports in the UK and Europe are associated with Little League elbow and shoulder?
Good question. Thanks, Sam. So we talk about Little League shoulder. We certainly don't see as much as we do in the States for both elbow and shoulder. But what we do see is this condition in tennis and in volleyball. Now, if you think about what we do in the UK, you might think, well, why don't you see so much of it in cricket? But if you think about the biomechanics of fast bowling, for example, you don't actually get so much strain at the shoulder. You get it a little bit more in the lower back, which is why when you do it repetitively, you tend to see more lower back injuries and shoulder injuries in cricket. With Little League elbow, once again, we don't see it half as much as they do in the States, but you do see it in sports where there's repetitive pitching. So the equivalent in the UK would be softball, really. Some baseball, but I suppose we see a bit more softball and once again, any other sports that involves a fair amount of throwing, really.
Thank you, Rick. Very clear. There's a question here, Noel. I can't let it go because there are two questions that sort of pertain to a similar thing, and it's something that came up, I think, in one of your talk, sorry, which isn't shockwave generally contraindicated for apophyseal injuries in children, particularly in the lower limb, due to the open growth plates and the sensitivity of the apophysis? What are you doing, Noel?
Thanks for the question, Sam. And so shockwave not contraindicated in apophyseal injuries. There was some concern, and I think absolutely correct concern on shockwave around the physis with some early histological studies that hasn't been borne out in further studies, but the shockwave in recalcitrant cases to the apophysis is different to the physis, the apophyseal injuries or traction injuries at the tendon attachment onto the bone. And it can be a useful tool in management for really challenging cases. Of all the and Osgood Slatters would be the most common site. I think it's a management option in at sort of tertiary level, and the sort of percentage of cases that I would think it's useful in or would use it in would be less than 5% of the difficult cases that I see of Osgood Schlatter. So certainly not for widespread treatment. It's worth consideration and caution regarding its use, but it is an option.
Really clear. Thank you, Noel, and thanks for answering that so directly. We're almost out of time, but there's one question which has gained a huge amount of traction in the last couple of minutes. I'm not quite sure why, but Scott, thank you for your question. And this is out there because I'm not sure who amongst us is wishing to answer this, but what are the presenters' opinions on adolescent athletes running in carbon-plated super shoes, and any age recommendations on incorporating them into training and or racing regimes? Who wants to jump in? I'm guessing Noel, Marco, Rick. Noel, you've come off mute. Go for it.
I was too hasty. Tricky question. Because there is limited research in this, limited work on this, and it's something that will require much more work. And so you're really coming at it from sort of the principles of the carbon plates, which do reduce the storage in the energy storage in the muscle and the tendon system, because the shoe and the carbon plate is doing that. So that is likely to improve adolescent performance, but at a potential cost for the development of the energy storing properties that are essential in muscle and tendon development for athletic performance. And as with so much of adolescent training at a high level, the question for the athlete and the coaches is about performance now and is about performance in the future, and future health and future participation and performance in sport in general should be prioritized. They will also change the mechanics and likely increase the ground reaction forces within the bones, which may increase bone stress injury. And there's some discussion regarding that, but we do need further work on that. So in summary, I would suggest caution, but wouldn't be sort of contraindicated. But I'd be interested. I know Aspetar have got a strong biomechanical and podiatric department, so Marco may have more information or more insight in that.
Marco, do you want to come in?
Yeah, like Noel said, we don't have a lot of data at the moment, and even in adults, actually, what happens with those shoes. Of course, we know that there is a performance gain. The issue is, what if athletes use them for training and do a lot of mileage in them? And we don't really know. There have been few reported cases of some injuries in the toes as a consequence of the fact that these carbon-plated shoes are pretty stiff in the front, and of course have a high profile as well, so it's a big drop. One of the other things to take into account is the fact that they are a little bit unstable on the back, so they're very good if you're running in a straight line. The moment you change direction or you're trying to go in a slightly different directions might be problematic, and that's what happens with children. So we don't know really the outcome. I mean, my advice would be just to use a variety of shoes if you have a possibility to do so, but also don't forget to do barefoot training too, because we are trying to develop intrinsic foot muscles in the age, and so we want as much variety as possible in these young feet. So I wouldn't confine them to a carbon-plated shoe yet.
Fascinating. Thank you so much. So I think we've overrun a little bit. I hope you don't mind us staying online a little bit longer than we'd thought we would, just to answer those questions. Any further questions, the team at ISEH will do their best. We'll do our best to try to answer those through social channels over the coming week. A couple of reminders. One is that this conference was recorded, and you'll be sent a link with the recording if you wish to watch it again. You might find answers to some of the questions that you may still have. And the other is, of course, to remind you once again that tomorrow's topic, further conference tomorrow, is on expert care for the collapsing athlete. So do tune into that. Otherwise, thank you to our speakers for some really wonderful talks. Thank you all for listening, and I wish you a good evening. Thank you.